Burns refer to any injury which is caused either to the skin or to any organic tissue, primarily by the heat, or it may be because of a radiation or some chemical substance or a cold. So it is any injury to the skin or any organic tissue in the body, which means that the skin is the most common organ which is involved in burns because it is the external barrier one. Second, it is the largest organ. So that is why skin is the most common organ which is involved in the burns. But it can be to any other organ, primarily by the heat, or it can be by cold also. It can be by chemical stimulus also. It can be by electrical injury also. So depending upon this, the burns can be classified on various types. So there are various methods to classify the burns. The first type of classification would be dependent upon the source of the burn. So according to the source of the burn can be a thermal burn, or it can be a chemical burn, or it can be an electrical burn. The major difference between a thermal burn and a chemical and electrical burn is that in thermal burn, there is a transfer of heat to the cells, and this heat produces cellular damage. Chemical and electrical burns, they themselves transfer heat, and this heat produces cellular damage. Along with that, the chemical and the electrical burns can directly cause a cellular damage. So the damage is much more in a chemical or electrical burn because they can transfer heat, and that heat transfers a chemical cellular damage, or the chemical and electrical source themselves can produce cellular damage directly. But in thermal, it is always either the heat is transferred or the cold energy that is transferred, which will produce a burn. Now, this heat or cold, the major difference is that cold will never cause coagulative necrosis, but heat causes the coagulative necrosis. So, when the heat is transferred from a source to an individual to produce the effects of burn, this heat can be transferred in three situations. Imagine there's a lady who is cooking in kitchen. She has a gas cylinder is there, and there's a stove, and she has kept sambar on one tawa, and the other tawa there's a idli pan. So there are three ways by which she unfortunately can get burnt herself. So the first way is that sambar unfortunately falls onto her, where it is a hot liquid that is coming in contact with the skin of the patient. So that is one type of the burn. The second type of burn is she would touch the hot idli pan herself. That is the second mechanism by which she can get a burn. And the third is, unfortunately, the LPG cylinder explodes. And when it explodes, there is a lot of air around her and the cylinder that gets superheated, and that will cause the burn. So that is another type of burn. So these type of burns, as I told, the first example would be a scald burn, where there is a hot liquid comes directly in contact with the patient, with the individual, and that produces burn. So that is a contact, hot scald. And then there is a contact burn. You call it as a contact burn if the patient directly touches a hot or cold solid. Hot or cold solid coming in contact with the patient is called as a contact burn. But if it is especially a hot liquid, it is called as a scald burn. And the third would be the flame. Flame is where the individual has not directly come in contact with the source of the burn, but the source of burn has produced a super oxidized and superheated air. This air will cause the injury to the patient. So, by last class, we had discussed about conduction, convection, and radiation. A flame would produce the effects because of convection and radiation because there is no direct contact. But a scald and a contact burn would produce injury because of a conduction. So this is because of conduction, the heat is transferred, and this is because of the flame, where there is convection or radiation that transfers the heat. Now, when this happens, the severity of the burn depends upon the following features. So the first, severity and the extent of the burn, both. The first feature would be the source, because thermal, they produce burn only by the action of the heat, transfer of heat, but chemical and electrical, they have their individual cellular damaging effects. So that is the source of burn is important. Second, if it is a flame burn, where the patient is not in direct contact with the source of burn. It is the air that is producing the effects. So in flame burn, what matters is distance. So the greater is the distance, lesser will be the effects, right? If the patient is far away from the source of explosion of a gas cylinder, so by the time the superheated air reaches the person, it will already cool down, and that is why it is of lesser chance than if the patient was close to the cylinder. So it is a distance that matters. But distance would never matter if it is a solid or if it is scald or a contact burn. Now, scald or contact burn, the patient touches the object and he gets a burn. He or she gets a burn. Now, this depends upon how much the object has an ability to transfer heat to the patient. If the object can transfer greater amount of heat to the individual, there will be more extensive and more severe burns. If it transfers less amount of heat, there will be less burns. It also depends upon the temperature, but at a given temperature, what amount of heat can a object transfer to the person who is in contact is called as thermal conductibility. So thermal conductibility is the ability of the object to transfer the heat to a person. Now, for example, if there is a boiling, there's a cooking oil and there is a grease, which are both at 50 degrees Celsius, which come in contact with a person producing a scald burn. Now, both of them are at 50 degrees Celsius, but the thermal conductivity of a cooking oil is around 4, while the grease has a thermal conductivity of 1. It means at the same temperature, the cooking oil can produce burn which are 4 times more severe, more extensive than the grease, even at the same temperature. It is because of the thermal conductivity. And the fourth would be the time of contact. See, if there are two people, a younger person and an older person, exposed to the same source of the burn, the younger person can remove himself from a source faster so that his time of contact is lesser. But the older person cannot remove himself faster. That is why his time of contact will be greater. Greater is the contact, greater will be the severity and extent of the burn. So this is the classification depending upon the type of the burn or a source of a burn, where it is thermal, chemical, or electrical. In thermal, it can be a scald, a contact, or a flame. And severity of the burn depends upon the source. It depends upon the distance from the source. If it is a flame burn, depends upon the thermal conductivity of the source if it is a scald or contact. Also, it depends upon the time of the contact. Right? This is one classification for the burn depending upon its source. So before going into other classifications, we'll try to understand the pathophysiology of the burn. So whenever there is a burn, the area it has local effects and it has systemic effects. So local effects will eventually lead to systemic effects, just as we discussed in chapter of sepsis. So whenever there is a burn, this burn at the point of contact. So if this is the arm, so if there is a burn exactly here, exactly at the point of contact, a thermal burn produces coagulative necrosis. All the proteins get denatured because of the high temperature. The cells get damaged and they will undergo necrosis. Because it is a solid organ, there is a coagulative necrosis. So this area at the center where there is coagulative necrosis, it has got irreversible damage. It cannot be salvaged. So it has got irreversible damage, and this is called as zone of necrosis, which is a centralmost area, which cannot be salvaged at all because it is gone already. Now, around this area, what happens? There is certain amount of thermal injury around this area, but the injury is not sufficient to cause necrosis. So, what it causes is it causes a vascular injury around this area where there is a increased vascular permeability. So, as I told you, as there is increased vascular permeability, the fluid just shifts out of the blood vessel and gets accumulated in the surrounding. This accumulated area in the surrounding will produce tissue edema. Now, this tissue edema will further reduce the vascular supply and this will again induce hypoxia. Now, this hypoxia, as we discussed in the chapter of shock, can lead to sick cell syndrome and it can eventually undergo necrosis. But if we intervene timely and if we prevent this tissue edema or if we reduce this tissue edema, then the cells get oxygenated and it becomes salvageable. So the second zone is called as zone of stasis. So this is a zone of stasis where there is increased vascular permeability and there is extravasation of the fluid that produces tissue edema. You control the wound factors, this tissue edema is reduced, this is salvageable. You do not control, you let it progress, or if the patient has come in the delayed presentation, then this will progress to hypoxia, which will lead to necrosis of the tissue. And the last area is always salvageable, which is a zone of hyperemia, where there is increased vasodilation because all the immune factors, immune cells have to come to the area of the burn. So there is area of hyperemia. Now this area of hyperemia is called as zone of hyperemia. So there are three zones. These are called as Jackson's level of burns. So Jackson's level of burns are in the center. There is zone of coagulation, which is coagulative necrosis, which is surrounded by zone of stasis, which is surrounded by zone of hyperemia. Now, zone of coagulation is unsalvageable. Zone of hyperemia is always salvageable, and our main aim is to convert this zone of stasis into zone of hyperemia so that it is salvageable. So this is about the Jackson's level of burns or the zones of burns. Now, what are the system effects when there is a burn injury? So whenever there is a burn injury, this will activate the severe inflammatory response. The inflammatory response is so severe that within moments, this inflammatory response will it is so severe that within moments, this inflammatory response will induce something called as genomic storm. Right? So it is not just the cells that change. 80% of the genes which are present in the circulating immune cells, they get altered. And there is decrease in the acquired immunity. The innate immunity remains same, but the acquired immunity reduces. So that is one of the reason for increased amount of sepsis in a burn because there is reduction in the acquired immunity. So the genomic storm happens as soon as the burn happens, and there is change in the 80% of the genes in the cell. And this will have a lot of features. One is it will stimulate the inflammatory cells and the release of inflammatory mediators. So these inflammatory mediators are histamine. The mast cells, when stimulated, will release histamine. They will release serotonin, they will release bradykinin, they will release vasoactive amines, prostaglandins, leukotrienes, activated complement. All of these are released. So all of this cause vasodilation plus increased vascular permeability. So what histamine does is histamine will increase the gap junction between the endothelial cells so that the permeability is increased. When the vascular permeability is increased, all the fluid will go into the peripheral in the interstitial space. So permeability is increased, all the fluid will come into the interstitial space. This fluid in the interstitial space will produce edema. As I told you, that cycle again just it's all about the basic pathophysiology of the shock. Edema causes hypoxia, hypoxia causes acidosis, acidosis causes coagulopathy. It is all the same flow chart as we discussed in the shock chapter. This is one thing. Second is because there is loss of fluid. This loss of fluid will result in hypovolemia. So it is not that fluid is lost into the body cavities or somewhere else. It is just a third spacing of the fluid. The fluid needs to be in the blood vessel because of increased vascular permeability. Fluid is outside the blood vessel. So this will essentially reduce the venous return. When venous return is reduced and diastolic volume is reduced, which will reduce the force of contractility, which will reduce the systolic PP. And a patient, any patient with a total body surface area of burns involving more than 15%. So more than 15% of body surface area is involved. He is prone for hypovolemic shock. And children, if more than 10% of body surface area is involved, are prone for hypovolemic shock. So that is why this is a criteria for admission. Any patient of more than 15% of body surface area or a child of more than 10% of body surface area needs to be admitted because that can lead to hypovolemic shock, and that is an indication for initiation of the IV fluids in these patients. So this is one cause for shock in a patient with burns. So this happens at a cellular level. Now, what are these changes that happen at a systemic level? Right? I hope you guys know about all the lactic acidosis and coagulopathy from the chapter of shock. So you can paste all of that into this flowchart to make it lengthier if this has been asked. Next is what systemic effects it has. First is we'll talk about the heart. So in severe system, because as I told you, there is increased vascular permeability that will reduce the venous return, which reduces the end diastolic volume, that reduces the cardiac output, which reduces the systolic BP. This is one thing. Second is these burns, when they affect the cause the cellular damage, these cellular damage will result in the release of the toxins. Or whenever the burn particles are present, these burn particles can also be toxic. So these will cause myocardial depression. And this myocardial depression can also lead to the cardiogenic shock. So one cause for shock was hypovolemic shock. This is hypovolemic shock, and it is cardiogenic shock. Other reason for shock in a burn patient is in burn patient there can be development of abdominal compartment syndrome. So if abdominal compartment syndrome is so much that it compresses the inferior vena cava, can anyone tell me what kind of shock it would be? Hello, hello, hello.
Yes, sir.
If there is abdominal compartment syndrome, that would compress inferior vena cava and reduce the blood supply to the heart, what kind of shock it would be? It is an example of obstructive shock. Obstructive shock is when there is a reduced filling, there's obstruction to the filling of the heart. It can be either because of external compression in the inferior vena cava, or it is a lymph node that is compressing on vena cava, or it is a tumor, or it is a DVT, or even abdominal compartment syndrome that is compressing the vena cava and preventing the blood to enter into the heart. So the cause for shock would be a hypovolemic shock, or a cardiogenic shock, or an obstructive shock. The second system would be, we'll talk about this respiratory system later because I want to tell everything about the inhalational injuries along with that respiratory system. And third, it would be a renal system. So in renal system, if there is shock, this shock will stimulate renin angiotensin aldosterone system plus ADH. So this will help in free water absorption. Renin aldosterone angiotensin will help in sodium plus water reabsorption. Now, when this does not happen, this will also lead to the oliguria. Now, shock causes damage to the muscles. If it has caused damage to the muscles, this will lead to myoglobinuria. This myoglobinuria can be a direct renal injury cause. Or whatever the toxins are present, these toxins can also cause acute tubular necrosis and that will damage the kidneys. The fourth would be a GIT. In GIT, as I told you, just as in shock, there would be a gastric dilatation. This is one. Second is these patients are apprehensive in burns and they swallow more air than breathing more air. So because they swallow more air, that will lead to gastric dilatation. So there's a huge dilated stomach. As I told you, this gastric dilatation can cause the stimulation of the vagus, which can lead to hypotension plus bradycardia. So it is essential to put a right tube in a patient with burns. So that is one. Second is it can also cause the paralytic ileus in the bowels. And third, it produces stress ulcers in the gut. So these stress ulcers will cause a damage to the mucosa. So they are the mucosal ulcers which are stress ulcers that are produced. So they are called as curling ulcers. So curling ulcers are the stress ulcers which are produced in the intestine. So that is third. And fourth is if you keep these patients for a prolonged period of NBM, even after the ileus is resolved, if you keep these patients NBM, that will lead to the gut atrophy. Now, all of this gut atrophy, a dilated stomach and dilated bowel with a breach in the mucosa, all of these are risk factor for translocation of bacteria. So when this bacteria translocates, that will lead to peritonitis that eventually leads to peritoneal edema. Along with that, any patient who is very sick elderly patient who has got major trauma, sepsis, they are all the risk factors for acute acalculous cholecystitis. So the patient can also produce gallbladder edema due to acute acalculous cholecystitis, and there can be even acute pancreatitis. So all of this with peritoneal edema can lead to abdominal compartment syndrome, which can lead to obstructive shock that potentiates the shock which is already there from the hypovolemic shock. So these are the GIT changes. There is gastric dilatation, there is paralytic ileus, and there are curling ulcer. If the patient is on prolonged NBM, that can even lead to gut atrophy. All these are risk factors for the translocation of bacteria, which can get infect the peritoneum, lead to peritonitis and peritoneal edema, eventually leading to abdominal compartment syndrome that may cause obstructive shock. Right? This is clear. Hello, hello. Next is inhalational injury. I want to talk especially about the inhalational injury. So this inhalational injury, or it is a respiratory system. What are the effects of burns on a respiratory system? Now you suspect a patient has got inhalational injury when in the following conditions. First is if the patient has a history of being trapped in a closed space. So any patient being trapped in a closed space always suspect inhalational injury because the closed spaces are made up of these materials, synthetic materials. When these synthetic materials they burn, they release carbon monoxide, which is the most common cause of death in a immediate death in a patient present where he has burns in a cold space is a carbon monoxide asphyxia. So it is carbon monoxide, or if lot of synthetic materials are used nowadays, it can also be a hydrogen cyanide poisoning. So when this carbon monoxide or hydrogen cyanide enters, they produce what is called as metabolic poisoning. So you suspect when there is a history of trapping in a cold in a closed space. Second is when this patient has any patient who has injury to his face or to the neck, you suspect an inhalational injury. And third, if the hairs on the face and on the neck they are singed, so it is burning of the hairs, singeing of the hairs on the face and neck. If that is present, you suspect an inhalational injury. Fourth is you examine the mouth of the patient if there are blisters in the mouth of the patient. So that is again a sign of inhalational injury. And fifth, because these can produce the edema of the airway if the patient has got hoarseness of the voice or there is a stridor. Again, this is a indication of an inhalational injury. So these are all the inhalational injuries. And the sixth, very important, is altered sensorium because the carbon monoxide will affect the brain and heart much more than any other body. So if the patient has got altered sensorium, you should suspect an inhalational injury. So either a trapping in the closed space, or there is burns over the face and on the neck, or there is blisters in the mouth, there is soot particles in the mouth, there is singeing of facial hairs and nasal hairs, and there is hoarseness or change in voice or stridor, or if the patient has altered sensorium, you should suspect an inhalational injury. So, what are these types of inhalational injury? It can be a inhalational injury from a hot gas. So, when the hot gas comes, this hot gas enters inside and this will cause an inhalational injury. When this happens, it is usually restricted to supraglottic because they disperse so fast that by the time they reach the glottis, they will have caused almost injury, right? So, no gas is left behind when it reaches the glottis. So that is why hot gases will mostly cause supraglottic injury and they produce laryngeal edema. Now, this laryngeal edema can set in anywhere between 4 hours to 24 hours and it takes at least 48 hours to resolve. Right? So, a patient is suspected of inhalational injury, and if there is a criteria for intubation, try to intubate this patient within 4 hours of injury. Right? If the patient fulfills the criteria for the intubation, I'll tell you later what is the criteria for intubation. So, if this patient fulfills the criteria for intubation, try to intubate him as soon as possible because after 4 hours of injury, the laryngeal edema sets in and supraglottic edema sets in, and that will result in difficult intubation. In such cases, you may need either cricothyroidotomy or tracheostomy. and you keep the patient intubated for 48 hours because it takes at least 48 hours for the uh, edema to resolve, and after that you can plan for extubation. This is first. The second importance is when the patient, we'll discuss it later again, but I'll just tell you for here because it is important. So if the patient had got an SCHAR at the present time of presentation, there are two ways of managing this SCHAR. Either you can take out the SCHAR immediately as soon as the patient has presented, or you can wait and do a staged burn excision, out of which the proponents for immediate extra excision tell that if the patient immediately presents, then you can utilize this 4 hours window where you can intubate the person without any difficulty. So that is called as anesthetic window, where to do escherotomy in the early hours, it is easier for anesthesia people to do endotracheal intubation because laryngeal edema would not have set. So that is why you can utilize that anesthetic window if the patient presents earlier and you plan a immediate burn extra excision. So this is the importance of that. The second is if it is a steam, it penetrates a little further, and this the gas, the hot air molecules, they spread a little further, and that will produce a subglottic edema. Sometimes it can even penetrate deeper and produce respiratory epithelial damage. So it can go a little deeper and can produce respiratory epithelial damage, and it produces a subglottic edema. Now, it can also happen because of these metabolic or smoke particles. These smoke particles, because these are particles, these are heavier, they settle down. They settle down in the alveoli and they produce chemical pneumonitis or ARDS. And to produce this chemical pneumonitis or ARDS, they take at least 48 hours. Right? Understand? So if it is only because of the hot gases, these hot gases produce supraglottic edema, which occurs rapidly. Within 4 to 24 hours, it develops and it takes 48 hours to resolve. But if it is because of a smoke particle, these smoke particles settle down, they take their time, they insert inflammation in the alveoli, and that produces a picture similar to chemical pneumonitis or ARDS that develops after 48 hours. And lastly, it can be also because of the metabolic poisoning. So these are the four ways how the inhalational injury can happen. One is because of the hot gases, because of which produces supraglottic edema, steam produces subglottic edema, and the smoke particles settle down, produce a picture similar to chemical pneumonitis or ARDS, or it can be carbon monoxide or hydrogen cyanide, which produces a metabolic poison. So we'll discuss about metabolic poison. Along with that, in the respiratory system, what is important is along with inhalational injury over a chest. So there is a deep partial thickness bones over a chest, or there is full thickness bones over the chest that will form an S-char. This S-char might limit the breathing because the skin is gone. Whatever the elasticity was present, it is gone. And if the muscles are involved also, that will prevent the patient from respiring. So there is a mechanical block to the respiration. So the respiratory system can be affected either by inhalation or by a mechanical block to respiration because of the chest wall injuries that will lead to the formation of an ischia. Now, this is the mechanism of inhalational injury. Along with that, what is important is when this happens, this is the source that is producing these injuries. Now, the body also responds, and this body also responds in a manner that aggravates this injury which is from the source. So, what happens is, so once there is this inhalational injury, because of any of these particles, once there is an inhalational injury, this will activate the immune system and this actually disrupts the ciliary epithelium. So whatever the respiratory tract is lined by ciliary epithelium, so this is the basement membrane. Along above it is the ciliary epithelium. Now this ciliary epithelium gets disrupted. So when there is disruption of this ciliary epithelium, along with that, the inhalational injury will elicit the inflammatory reaction, which will increase the lung lymph production. When the lung lymph production is increased, this will cause the increased hydrostatic pressure in the lymph that will transudate the proteins. The proteins get extravasated. Now, these extravasated proteins in the lumen of the tracheobronchial tree and the disrupted epithelium right? The epithelium which is disrupted along with the transudated extravasated proteins forms what is called as a fibrin cast. So a fibrin cast in a lung is formed by the epithelium, ciliary epithelium that is disrupted and the proteins that are transudated. Now this fibrin cast cannot be taken out by just by cuffing or by simple suctioning methods. This fibrin cast has to be dissolved. So that is why this fibrin cast is difficult. A mucus plug can be taken out by cuffing or by suctioning, but a fibrin cast is difficult to express out. This is one. Second important thing is this fibrin cast can lead to what is called as ball wall effects. What is ball wall effect is if this fibrin cast goes and gets dislodged into this alveolus. So when it gets lodged into this alveolus, it is blocking this alveolus. But when the patient inspires, the lung expands. When the lung expands, alveolus stretches. So when this alveolus stretches like this, air will go inside. Now once the air goes inside, this air gets distributed to the capillaries. And when the patient expires, lung collapses and this alveoli also collapses. When this alveolus starts to collapse, the initially little air is expired out, but later this fibrin mucus forms a block because in inspiration, even though it had blocked, because the patient was inspiring, there is stretching of this alveolus and the air will rush in. But while expiring, it is collapsing, so a very little air will come out, but most of the air remains inside. So that leads to air trap in the alveolus. So this is called as ball wall effect. So where in inspiration air goes inside, but in expiration air gets trapped inside. So when the air gets trapped inside, every time the person breathes, more and more air gets trapped inside because of this ball wall effects. So there are two effects of this. One is because more and more air is getting trapped, it can lead to barotrauma, and this barotrauma can lead to pneumothorax. So this is might be the cause of a pneumothorax for a patient in burns. So burn patients are, especially if the patient has inhalational burns, they are more prone to develop this pneumothorax because of the barotrauma due to the ball wall effect. One. Second, when you give conventional ventilation to these patients, give a lot of positive end expiratory pressure, which can further accentuate this barotrauma and may lead to compromise of the pneumothorax. This is first. Second is this air is not good because there's only quantity of air that is present inside the alveolus, but it cannot diffuse. Whatever the oxygen is there, that oxygen will be taken by the blood there, but new air cannot come inside. That is why it cannot get oxidized, and the blood that flows through there cannot get oxidized. So that is why even though there's a quantity of air, there is no oxygen that can lead to hypoxemia. Less oxygen in the blood, hypoxemia. And the third important thing is when this air gets trapped inside, the carbon dioxide can also not get out, and the carbon dioxide leads in present is present in the blood, and that can lead to the hypercarbia. So these are the effects of the air getting trapped inside. So this is one mechanism by which the body responds to the inhalational injuries. Now, what happens when there is metabolic poisoning? This metabolic poisoning, all these combustible gases, they mainly produce carbon monoxide, but they also produce hydrogen cyanide. Now, this hydrogen cyanide normally in the body is converted into thiocyanide. Now, this thiocyanide can be excreted into the urine. But this hydrogen cyanide, when there's a lot of production of this hydrogen cyanide, it cannot be effectively converted into thiocyanide. These hydrogen cyanide ions start circulating in the body. When they circulate in the body, they will interfere with the electron transport chain and they block cytochrome A3. Right? So cytochrome A3 is blocked by these circulating cyanide ions. And when there is a block in electron transport chain, there is no production of ATP. And further, there is a sick cell syndrome and all that happens. So that is why cyanide produces this type of poisoning. So to combat that, you need to reduce the amount of cyanide. So you give IV methylcobalamin, which is actually a B12 injection. So this is for cyanide poisoning. Now, what carbon monoxide does? So the carbon monoxide first point is that its diffusability is very much greater. It can easily diffuse from the alveoli through the respiratory epithelium into the blood vessel. Its diffusability is very much better than the oxygen. The second thing is this carbon monoxide has affinity of almost 250 times than that of hemoglobin, and it is a than oxygen to the hemoglobin, and it is a competitive antagonist. That is, for example, if the oxygen is already bound to hemoglobin and carbon monoxide comes in contact with hemoglobin, it can easily displace the oxygen because its affinity is 250 times. So, to displace one molecule of carbon monoxide, we need 250 molecules of oxygen. But 250 molecules of oxygen can be easily displaced from the hemoglobin by carbon monoxide because it is a competitive binding and its affinity is much higher. So it forms carboxyhemoglobin. Now, once this carboxyhemoglobin is formed, what it does is, I hope you all know about two hypotheses about a enzyme and a substrate. One is lock and key hypothesis. So, lock and key hypothesis states that there is a rigid conformation between a substrate and a enzyme. So, if the substrate has a conformation like this, enzyme has a conformation like this. So, this is a lock and this is a key, so that when they bind together, this enzyme can bind only to this substrate and not to any other substrate, so that this substrate will bind to the enzyme and the process happens. This is lock and key hypothesis. But later they found out that there are limited enzymes, but there are innumerable substrates, and a single enzyme can be a enzyme for a lot of substrates. So they came with this conformational hypothesis, which means that according to this lock and key model, what was supposed was there is a rigid conformation between the enzyme and a substrate, which allows the binding only of a proper enzyme and a substrate. But a conformational model tells that there is no rigid conformation, but when a substrate comes in contact with an enzyme, this substrate will induce the conformational changes into the enzyme so that it can bind and it can change itself according to the uh, conformation of the substrate. So similar thing happens here also. When this carbon monoxide binds with hemoglobin and forms a carboxyhemoglobin, it induces conformational changes in the hemoglobin so that the hemoglobin, what is the function of the hemoglobin? It is to load oxygen at the respiratory epithelium and unload oxygen at the cell. So when it comes near the cell, because carboxyhemoglobin is inducing conformatory changes in the hemoglobin, it cannot offload oxygen at the cell. So already the amount of loading is only reduced. Along with that, whatever is being loaded, it cannot be unloaded at the cell because it causes conformational change, which is essentially a left shift of the hemoglobin saturation curve. And the fourth would be, even if this little amount of oxygen enters into the cell, this carboxyhemoglobin will carbon monoxide can also diffuse into the cell. This carbon monoxide will inhibit cytochrome oxidase, which is again a part of electron transport chain, and then no ATPs are produced. Now the cells are forced to undertake anaerobic respiration that will produce lot of lactic acidosis that produces coagulopathy, and this cycle keeps on repeating. Right. So remember, hydrogen cyanide inhibits cytochrome A3, carbon monoxide inhibits cytochrome oxidase. So carbon monoxide has better diffusibility, has 250 times more affinity to hemoglobin, so it displaces whatever the oxygen that is already bound. But when it comes near the cell, it induces the conformational changes that it cannot offload oxygen at a cellular level. And third, it can, if even if the oxygen is unloaded, it can directly enter the cell and inhibit the cytochrome oxidase as a part of electron transport chain. So this is a spectrum of the events that happens when there's a carbon monoxide poisoning. And it is proportional. Greater is the carbon monoxide poisoning, greater will be the effects. So the first organ which is affected would be a brain and then the heart, because these are the organs which are very much dependent upon the oxygen. So anything more than 5% will have significant effects. So if the percentage of the carboxyhemoglobin is more than 10%, then the patient will start to feel headache. If it is more than 20%, the patient will have dizziness. If it becomes more than 30%, now the patient is developing dyspnea. If this becomes more than 40%, the patient will have severe obtundation and can go into coma. That is why altered sensorium is also a factor which points towards the inhalational injury, especially the carbon monoxide metabolic poisoning. So these are the percentages along which the severity increases. Now, we'll just finish off the treatment part of this inhalational injury here only. So, how to treat these patients? Patients with inhalational injury. So, the first, it all again depends if there is a laryngeal edema. I told you the laryngeal edema will start within 4 to 24 hours and it will resolve by 48 hours. But the ARDS or the chemical pneumonitis will set up after 48 hours. That is why we have classified this inhalational injury to the lung as three stages. So the first stage, second stage, and the third stage. In first stage, there is stage of acute pulmonary insufficiency, right? So in acute pulmonary insufficiency, there can be asphyxia. So asphyxia is the most common immediate cause of death. And there is carbon monoxide poisoning or the hydrogen cyanide poisoning, metabolic poisoning, and then there is laryngeal edema. So these patients develop within 4 to 24 hours. The second stage would be a clinical stage similar to ARDS. And in these patients, the patients will develop infiltrates in the lung. And this is characterized by less oxygen in the blood because the respiratory epithelium is inflamed. There is a lot of edema. Water oxygen is given to the lung. It is not able to diffuse into the blood. So the amount of oxygen in the blood reduces, and that produces what is called as hypoxemia. Now this will develop more than 48 hours and will be present up to the third or the fourth day, which can go up to 72 or the 96 hours. Now, the last stage is where these patients develop infection in the lung, which is bronchopneumonitis or tracheobronchitis. So, these patients develop bronchopneumonitis, and on X-ray, there is a patchy consolidation. And this can happen anywhere between 3 to 10 days. And first 3 to 5 days, the most common organism that is involved is a Staphylococcus aureus, which is usually methicillin resistant. MRSA is the most common organism involved in the third day to fifth day of a inhalational injury. But if it is skin, it is always GABHS. Group A beta hemolytic streptococci is the most common organism involved in a skin burn, and most common organism in inhalational burn, first 3 to 5 days is a gram-positive Staphylococcus aureus, and then after 5th day to 10th day, it is a gram-negative organism which is Pseudomonas or Klebsiella can be input. And this stage is also complicated by ventilator-associated pneumonia because it is already 72 to 96 hours which is elapsed after ventilating the patient. Also, it is complicated by ball valve mechanism. So there is increased, these two again will increase the risk of cardiac trauma. So these are the things that need to be remembered. So these are the clinical stages of lung injury from a inhalational injury. Now, how to treat? So the first thing in treatment of this patient would be airway. This, especially this inhalational injury I'm telling, we'll talk about the burns per se a little later. Right? So airway injury, you need to maintain the airway. So if the patient has already developed laryngeal edema and is there is a need for intubation, you do not delay the intubation and you intubate the patient. So early intubation actually saves life in these patients. So if the criteria for the intubation is fulfilled, which is the first sign of declining pulmonary inflammation, pulmonary function would be SpO2 of less than 92%. Okay. So if SpO2 drops to less than 92%, which is associated with increased respiratory rate, and the patient has hypercarbia. So there is lot of carbon dioxide in the blood because it is not being expelled out. And if this is by PaCO2 of more than 45 mmHg, so if these three are present, you take an ABG, PaCO2 is more than 45, clinically respiratory rate of the patient is high, and the saturation drops to 92%, you intubate the patient. If already laryngeal edema is set in and intubation is difficult, if it is not possible, you go with cricothyroidotomy or the tracheostomy of these patients. If it is not, then better do not try to, unless this criteria is met, try not to intubate the patient. I'll tell the reason later why. So this is about airway. Second is this airway is blocked one by edema. Second thing is this can be blocked by secretions. Now these secretions may be, as I told you, a mucus plug or it can be a fibrin cast. Now this mucus plug, the patient coughs out and it can be cleared, but a fibrin cast cannot be cleared because it is a protein plus ciliary epithelial debris which get inspiciated, and this can lead to ball wall mechanism. Now, to make this fibrin cast soluble, you can use nebulizations. So, what are the nebulizations that are available? So, first thing is the nebulization for a fibrin cast is heparin. You take heparin of 5,000 units and you mix it with 3 ml of normal saline and you give nebulization every 4th hour. Initially, this IV heparin was used in burn patient, but you know IV heparin causes coagulopathy. Already in burns patient, there is acidosis and there might be hypothermia also that will lead to coagulopathy. So that is why it is stopped. Now, only form of heparin to be used is a inhalational heparin. So 5,000 units in 3 ml of NS. Now, to break this mucus plug, you can use a nebulization of N-acetylcysteine. You get a 20% N-acetylcysteine, which is of 3 cc, and you give it every 4th hourly. It is 6 times a day, which will break the mucus plug. But the third reason for airway compromise is because these burns release vasoactive amines, histamine, bradykinin, they cause bronchoconstriction, there is bronchospasm. So to prevent this bronchospasm or to treat the bronchospasm, you add nebulization with a beta 2 agonist. It is only beta 2 agonist, right? Which is given secondarily, right? A beta 2 agonist nebulization secondarily, heparin and saline nebulization 4th hourly, N-acetylcysteine nebulization has to be given 4th hourly. This is mandatory. Along with that, if the patient is not able to cough, you can induce cough by giving a nebulization of 3% NS. Right, hypotonic saline induces cough, so you can use because cough is the most effective way to clear the secretions, not the bronchoalveolar lavage, not the endotracheal suction. Cough is the most effective way. That is why try not to intubate the patients when the criteria is not met, because cough is the most effective way to clear the secretion. If the patient cannot cough, you can induce cough by giving a 3% NS solution. Along with it, you intubated the patient, you extubated the patient also, but post-operatively, because of this endotracheal tube, patient might develop edema. So for post-extubation edema, you get a racemic mixture of epinephrine. So this epinephrine will reduce the edema, right? So you can use a nebulization of this edema. Right? So, but it is a general practice to prescribe acetylene plus budecort nebulization, but try not to give steroid inhalation as a nebulization. Always in burns patient, try to give only beta agonist inhalation. If, for example, the patient was a asthmatic who is a steroid dependent previously, in such cases, you can give a steroid nebulization. Or with all this conventional nebulization, if the bronchoconstriction do not get relieved, then you can add a steroid nebulization. So, steroid nebulization is not indicated routinely. Steroid nebulization is indicated only if the patient is resistant to conventional nebulizations or the patient is previously steroid dependent for any of the upper respiratory tract infections or pathologies. So that is about steroid. So these are the ways by which you manage. And then when the patient has developed bronchopneumonitis, there is a cuff, there is a fibrin cast. This fibrin cast, if it is not coming with heparin also, then you need to do a bronchoalveolar lavage. So this comes after 3 days because when bronchopneumonitis has set in, so bronchoalveolar lavage, multiple bronchoalveolar lavage with extraction of the inspiciated fibrin cast is needed. This is fifth. And sixth, prophylactic antibiotics has no role, right? So if the patient has inhalational injury, only inhalational injury, do not rush to give prophylactic antibiotic unless the patient has a clinical evidence. If the patient is not improving after 48 hours also, after 72 hours also, or there is a clinical evidence of raised CRP in these patients. So if there is a blood culture is positive, if the patient has developed bronchopneumonitis, if the patient is producing lot and lot of cough and sputum, only when there is a clinical evidence or suspicion of infection, you give an antibiotic that covers gram positive, gram negative things. If not, prophylactic antibiotics have no role. That is fifth. And next is how to ventilate these patients. So when you ventilate these patients, again, because of the ball valve mechanism, there is increased risk of barotrauma. So you need to reduce the barotrauma. So that is why you reduce the positive end expiratory pressure. Now, in a convention, you put the patient on conventional ventilation, but you reduce the positive end expiratory pressure. But if the patient does not respond to this conventional ventilation, you can put him on something called as HFCR, which is high frequency percussive ventilation. So what happens in high frequency percussive ventilation is here you give anywhere between 60 to 20 breaths or cycles per minute. The machine is giving anywhere between 60 to 20. Here the machine gives around 200 to 500 breaths per minute. So it is almost 20 to 30 times greater. So it is giving 200 to 500 breaths per minute is given, but it is a smaller breaths, more frequency breaths. So what it does is it reduces the chances of the barotrauma. Also, it reduces the fibrin cast formation, right? It can also inhibit the fibrin cast. It can break the fibrin cast that is formed. So you initially you put on the conventional ventilation. If the patient does not improve, you can put him on the high frequency percussive ventilation. Along with that, you try to keep the patient in a propped up position, and you try not to result in hypothermia, because hypothermia results in acidosis, again increases the respiratory rate, that all the same pathology. And you try to extubate the patient as soon as possible, because you don't extubate, the mucus and the fibrin cast remain inside, and suction is not such efficient way as compared to cuff. So you try to extubate the patient as soon as the patient can is conscious, patient is able to cough, and the patient can sustain without a endotracheal intubation. That is. So when it comes to metabolic poisoning, any patient who is suspected to have metabolic poisoning should be put on high flow 100% oxygen, because as I told you, it is a competitive antagonist. So if one molecule of carbon monoxide can displace 250 molecules of the oxygen. So if there is one molecule of carbon monoxide you need to displace, you need to give 250 millimoles of the 250 molecules of the oxygen. So because it is a competitive antagonism, you need to give high flow 100% high concentration oxygen. Sometimes you may also need hyperbaric oxygen, which is a high pressure, high flow, high concentration oxygen. So this is all about inhalational injury, right? Is this clear, guys? Hello.
Yes, sir.
So that was about inhalational injury. The next topic is again we'll get back to classification of these burns. So depending upon the severity, these burns can be classified as a minor burn, a moderate burn, or a major burn. Right? So these are classified as minor, moderate, major burn. Major burn is also called as a severe burn. To tell it as a minor burn, if it is a partial thickness burn, the total body surface area involved should be less than 15% if it is an adult, and less than 10% if it is a child. But to call it as a major or severe burn, a partial thickness burn of total body surface area should be more than 25% in an adult and more than 20% in a child. It is between these two, a partial thickness burn of a total body surface area of 15 to 25% in an adult and 10 to 20% in a child. This is called as a moderate burn. Now, this, if it is a full thickness burn, Less than 2% of body surface area, be it an adult or a child, 2 to 10% of the body surface area, and more than 10% of the body surface area if it is involved. Along with that, if it is a inhalational injury, it comes to severe burn. If it is an electrical injury, it is a severe burn, irrespective of the amount of the area, total body surface area involved. If it is an inhalational, if it is an electric burn, if the burn is associated with a fracture or any major mechanical trauma. If the patient had got a burn, he's standing on the roof, he fell down from the roof, he has got multiple injuries. There's a splenic trauma associated with the burn, there is a chest injury associated with the burn, there is a long bone fracture associated with the burn. All of that come under severe burns. And if there is any injury to the face, especially the eyes, the ears, genitalia, and the perineum. So if any of this is there, inhalational, electrical, burn with a fracture, or burn with major mechanical trauma, or any burn over the face, eyes, ears, genitalia, perineum, all these come under severe burns, irrespective of the total body surface area involved. So this is depending upon the severity. The first classification was based on the type, source of the burn. The second was severity, and the classification, which is of more importance clinically, is the extent of the burn, the depth of the burn, or the deeper extension of the burn. So initially they used to classify this as first degree, second degree, third degree, and fourth degree burns. But now we classify them as a superficial burn, partial thickness burn, and a full thickness burn. A superficial burn is a first degree burn, partial thickness burn corresponds to a second degree burn, full thickness burn corresponds to a third degree burn and a fourth degree burn. Right? A superficial burn, a partial thickness burn can be a superficial partial thickness burn, or it can be a deep partial thickness burn. Right? So these are the things: superficial partial thickness, deep partial thickness, full thickness burns, which are third and fourth degree burn. A superficial burn involves disruption of epidermis only. The dermis is not at all involved. In a partial superficial thickness burn, the papillary dermis is involved. In a deep partial thickness burn, the reticular dermis is involved. In a third degree burn, the subcutaneous tissue involved, and in a fourth degree burn, a muscle and a muscle or a bone is involved. Here, because epidermis is involved, epidermis is disrupted, and there is a underlying nerves which get exposed. Because of that exposure, this is a painful in nature. Papillary dermis is also painful, but in deep partial thickness, most of the nerve endings are gone, yet some amount of nerve endings will be present. So these patients have something called as pinprick sensation. Here there is no skin only, but the skin is replaced by eschar, so that has a insensitive eschar. Now superficial burn will not have a blister, because for a blister to form, dermoepidermal junction has to be involved, which happens in a superficial partial thickness burn where blister is formed. A deep partial thickness burn may have blister, may not have blister, depending upon the involvement of the dermoepidermal junction. If it is completely vanished, again there is no blister. Here there is no question of blister only. Here the capillary refill is present. Here also the capillary refill is present. But here it is absent, and here there is no question of capillary refill because the vessels are all thrombosed. There are thrombosed vessels with insensitive eschar, which gives the appearance of a charred parchment-like appearance. There is a charred skin. Now, because capillary refill is present, this becomes red in color, erythematous. This also looks red in color because there is capillary refill which is present. You press, it blanches, you leave, it comes back. So that is what is capillary refill, right? Here there is no capillary refill, so it is pale and mottled in appearance. And this has got thrombosed eschar. So when this eschar forms, depending upon the source, don't think that eschar is always black. It can be a black eschar, it can be a white eschar, it can be even a cherry red eschar also. It can be anything. So here, because only the dermis is involved, only the epidermis is involved, it can heal spontaneously because of the retear ridges which are present and that will help in the epithelialization. Now, this can also heal spontaneously. This can also heal spontaneously. This cannot. The third degree requires a graft. The fourth degree will require either a graft or a flap. And when it heals spontaneously, it heals from the whatever the epidermis is left, right? It is not complete destruction of the epidermis. So whatever the epidermis is left, from there only it heals. Now the partial thickness superficial burns, the hair follicles penetrate inside. So they generate from the keratinocytes which are present in the hair follicles, or sometimes this epithelium projects into the dermis. This is called as retearages, which are the epidermal projections into the dermis that also call have keratinocytes. So from these keratinocytes it generates. So either it is from the hair follicles or from the keratinocytes of the retearages. Now this germinates, this develops from the keratinocytes which are present deeper in the sweat glands. Now, one more clinical difference between a superficial partial thickness and deep partial thickness is that here the hair follicles are intact, so you gently pluck can hair, it will not come out. But a deep partial thickness, you just pass your hand over the skin, the hair follicles will get removed from the skin. This is because the hair follicles are involved, there's complete destruction of the dermis there. Now, when this heals, it will not form any scar, and this will also not form any scar. But here the dermis is gone, the dermal gap had to be closed. To close that gap, there is recruitment of the myofibrils, which will contract and they produce a scar, right? They inevitably produce a scar in a deep partial thickness burns. So these two do not produce scar, but the difference is that this looks same as that of the normal skin when healed, but this can have some discoloration or there can be some hyper or hypopigmentation. There is some change in the texture, but a superficial wound will always look same as that of a normal skin. And this will heal within first week. It takes only 7 days to heal. This heals in the second week and this heals in the third week, right? So it is 0 to 7 days, 7 to 15 days, 15 to 30 days. So it is in the third or fourth week, second week, and first week. So these are the differences between these are the clinically you classify the depth of the burn, right? Is this clear? Hello? Hello?
Yes, sir. Yes, sir.
So this is about the depth of the burns. Now, how to treat these patients? So treatment is in the pre-hospital setting and in the hospital setting. So in a pre-hospital setting, what all you can do is first is always it is scene safety. Along with scene safety, you need to make sure that you call for help. And when you call for scene safety and have taken care of this, the second important thing would be always airway, breathing, circulation. And then you need to, sorry, before this, you need to stop the burning process. So you take care of the scene safety, call for help, and you stop the burning process. Then you take care of ABC. Then you cool the patient. So it is cooling is to bring the patient back to the room temperature, not to induce hypothermia. So for this, you need to run water. You don't just put a wet cloth onto the patient. So you need to run the water continuously for 20 minutes over the wound. This is effective up to 1 hour as per Bailey, but can be effective up to 3 hours also as per Sabiston. But after 3 hours, it induces hypothermia. It is not effective. So what it does is it reduces the microvascular damage and also it reduces the pain. So it is a good analgesic and it also slows down the microvascular damage. Now you need to use what is called as tepid water. So tepid means which is at the room temperature. So 15 to 30 degrees Celsius. Anything can be used, but a 15-degree water is better. Run for 20 minutes, effective up to 3 hours, which reduces pain and reduces the microvascular damage. And fourth is you transport this patient to the hospital. If you suspect an inhalation injury, always give a oxygen. The reasons I told you. You keep the patient in a propped up position and while transporting. and then you keep the limb which is affected in elevated position, because if the limb is not in elevated position, already there is a stasis that will increase the venous stasis. This venous stasis will again lead to edema. All those things happen. So you try to keep the limb in elevated position. And sixth is analgesia. Remember, for all practical purposes, whenever you want to give a analgesic to the burn patient, please do not give a IM injection. Always give a IV analgesic to a burn patient. This is because what happens is, in burn patient, there is vasoconstriction in the periphery, as we discussed in shock chapter. So when you give a intramuscular or the subcutaneous injection to preserve blood supply to the vital organs, the skin, the muscle, the subcutaneous tissue reduce their blood supply. This is called a shunting, as we discussed earlier. So this shunting will reduce the blood supply in the peripheral skin. So whatever you give the drug, it will not be absorbed. So the patient will not have analgesic effect. One. Second is, this drug remains in the subcutaneous tissue, and when the patient recovers from the shock, there is vasodilation. So, in the later stages of burns, there is a vasodilation. Now, all this amount of the drug which you given over a period of time, for 3 days, you give IM injection, it is not absorbing into the blood, which is not helping the patient on one hand. On the other hand, for 3 days of this dose will be sequestered in the muscle or the subcutaneous tissue. As soon as there is a vasodilation, all of this will enter into the blood and that produces toxicity. So analgesics in a burn is always IV.